The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, everyone. Good day to you, and welcome to our podcast, TMD Demystified. I'm Tony Urbanek, and Naomi Engelman is with us also on the podcast. Naomi is our Director of Education and Marketing for TMJ Services, and we will ask her some questions in a little bit. But today's topic regarding TMD, I wanted to go over in a little more detail comments I made earlier about how this all came about. And it really surprised me how it all came about. And I've told this story literally hundreds of times, so I have no problem telling the story, but I want to tell it to you kind of fresh and get you an idea of how this came about, that an oral and maxillofacial surgeon claims he found a non-surgical solution for TMD that it really solved the problem non-surgically. For 30 years, I did what my colleagues and the textbooks and the lectures said to do surgically about temporomandibular joint problems. Very limited in scope, really. My surgical colleagues didn't delve into much about really what causes TMD. It was all about doing something within the joint to make the TMD go away, the symptoms go away. The consensus out there for years, it had something to do with the disc, and the disc being not in the right place, and the disc being beat up, and the disc having a hole in it. And I got it. I read all the journals and articles and books, and I got a whole library. There's my library. A lot of that having to do with TMD. Of course, orthognathic surgery, cleft palate. I did a tremendous amount of cleft palate work, orthognathic surgery in my career, but I did 2,000 surgical cases on the temporomandibular joint. And about 10 years ago, I came in one morning and I said, I just can't do this anymore. I had a couple patients that I had done surgery for a year ago, whether it was 6 months or 2 years. But what I found was usually within 6 months to 2 years, a good portion, let me just say, kind of guess, 30% of the patients would be back in my office with more pain. I was doing surgery for patients, and at least 30%, if not approaching 50%, within time, were back in my office saying that their symptoms were back, whatever their symptoms were that I tried to fix surgically. That was very disappointing for me. It was very disappointing for them. So I came in one morning and I just pulled the trigger and I said, I'm not doing any more TMJ surgery. And I just made up my mind. And from that point on, I just said, I don't do that. I can't help you. This was roughly 9 years ago. And I put down the scalpel. At the same time, because of my training in the sciences, besides dental school and medical school, I also have training as a academician. Actually, for a time I was going to be an academician. So I have a master's degree in cell biology and anatomy, and I also actually did a PhD along with my MD, although I don't claim it because I didn't finish I finished the research. I did not publish. And that's a different story. But in any case, because of that background, and because I had actually done independent research for the NIH, I had my own research project funded by the NIH regarding facial growth of the facial skeleton. I was a research fellow for 2 years with the NIH. I was not afraid of research. So literally within a few hours of saying, I'm not going to do any more surgery, I took it on myself to see if I could figure it out, because we all know nobody figured it out. And I like to solve problems. So when I made that decision, within a few days, I had no lack of people who wanted to come in and have relief from their symptoms, patients. And you know, it's 95% females, 5% males. So I had no lack of female patients who wanted to come in and have treatment of some kind. And so doing research, the first part about research is going right to the source. So rather than read more journals and go to more lectures and read more textbooks and do what my colleagues said to do about temporomandibular joint, I started talking to the patients. And I would sit down with a patient for 20 or 30 minutes and I encourage her to tell me everything she knew about the problem, everything she thought she knew about the problem, what her husband thought he knew about the problem. When does the dog bark when it hurts? What phase of the moon is it when it hurts? What does her husband say about it? What does she think is it? What kind of weather is going on? And I heard a lot of things that I had heard before about the temporomandibular joint or their symptoms. And I'd encourage them to go on for 20, 30 minutes, sometimes 45 minutes. And I would just sit there silently and listen. I'm just collecting data. And I heard this multiple times. Of the first dozen patients, I heard 6 or 8 times, if I put my finger or my thumb or a pencil eraser or a pen or my tongue or a piece of cloth between my front teeth and gently bite down, it feels better. After it took a while for the light to finally go off, and I went, I wonder if I make a device that the patient can wear, they can speak with, and they can wear long enough, what will happen? So I went in my little lab, Papa Giacchetto lab, and I made a little device of my own design, and that fits in the mouth, that does nothing more than have the front teeth touched, anterior 6, and separate the posterior teeth. And that is this little gizmo right here. And mine didn't look anywhere nice as this, but it did the same thing. It looked like that. And I put it in the woman's mouth. I made one and she came back in a few days and I said, put this in your mouth, keep it in 24/7 except when you eat, and come back in 3 weeks. I want to see you. And this is a woman like most of my patients, even to this day, who have 10 years, 20 years, 30 years. The average person I see with this problem has 15 to 20 years of symptoms before they come in to see me. That is huge. But in any case, she was typical. She had 20, 30 years of pain, headache, earache, jaw pain, neck pain. Those are the big four. The big four: headache, earache, jaw pain, neck pain. She came back in 3 weeks. I walked in the room and I said, Molly, how you doing? And she said, thanks, Dr. Urbanik, my pain's gone. And I looked at her, I said, really? And she looked at me like, why are you surprised? She didn't know that she was an experiment. But as it turned out, she wasn't the only one that had that response. I literally I backed out of the room a step or two, and I said, how much of your symptoms are gone? And she looked at me again. She says, all of them. I was stunned. I literally was stunned. And I don't want to go on about the drama of it, but I was surprised. And so I followed her along a while longer, and they stayed away. And then we went from full-time to part-time to nighttime only. And then I did a few others and a few more and a few more. And by the time I had a litany of 50 cases under my belt like this, I went, what's going on here? I mean, literally, like, I had no idea how it worked at that time. It's like all I did was separate the back teeth for a long enough period of time. Why am I getting this great response? And then I went back to the books. Then I went back to my anatomy and cell biology training and my experience doing research and et cetera. And I figured out why, which I explained in the last episode. Why does inflammation within the temporomandibular joint eliminate all of those disparate symptoms. So if you didn't see the prior episode, go back to the prior episode, I'll explain it to you. And that's what's going on. And that is how this all started. That was roughly 9 years ago. Then at that point, I went, I can't treat all these people myself. I need other people to do it. And simultaneously, I wonder if I can put a patent on it. And yes, it took 4 years to get, I can tell you all about getting patent law. That's crazy. But yes, it took 4 years to get the patent. And then after that, we were assured that we had that. Then it took another 18 months to get FDA clearance and approval to teach it and have other doctors use it. That's a fact. And so for the past 2 years since we got the FDA approval roughly, we're on a mission. I'm on a mission to actually, we've solved the problem. That part of the mission is done. I mean, we've invented the airplane that flies. Now we have to, get everybody to believe that you can get in an airplane and travel from one end of the country to the other. And, like aviation was at the beginning, everybody was very skeptical. I'm an aviator, been aviator for 52 years. And so I compare a lot of things to airplanes and aviation. So there was a lot of skepticism about aviation back when Orville and Wilbur first flew. And, but I'm on a mission to make sure that as many people, especially women, as possible who wake up every morning with headaches or earaches or shoulder pain or ringing in their ears have relief and don't have to go through procedures, surgery, dry needling, Botox, medication, narcotics, and a whole other litany of things that don't work and at sometimes are devastatingly damaging. And to eliminate that from what's going on in our medical system throughout the United States and hopefully beyond. It's quite simple. So that's how it all started. And now our company is developing a network of doctors throughout the United States who use the device and protocol like I do. And we've learned how to market it to other doctors, other providers. Network providers would include other physicians, dentists, oral surgeons, orthodontists, PCPs, ENTs, neurologists, and especially nurse practitioners, physician's assistants, physical therapists, even massage therapists, people who deal with these symptoms day in and day out. And when they see them walk in their door, don't know what to do about them, don't recognize them, misdiagnose it, mistreat it, misdirect it. And now that I've seen, I had no idea how big this was. I mean, doing surgery for 30 years, I was just one patient at a time would come in. And then when I really got into it in the non-surgical way, and I saw all these patients and listened to their stories in depth, it's just a huge problem. And the numbers of patients who have this problem is extreme. That's a whole other episode of how I can tell you how I know that 45% of women have temporomandibular joint symptoms of one kind or another. We'll talk about that again sometime. I don't have time. So Naomi's with us here today again. And because, again, Naomi has significant experience going into all of those practices and talking to all those practitioners and doctors, every category, and listening to their questions about, what we've developed here and why we know it is successful and what our experience is. So I wanted to ask again, Naomi, to enlighten us a little bit about the questions that she gets from some of these different categories and see if we can answer some of those for you. That I'm sure you have some of the same questions. So what do you hear out there, Naomi, when you visit the different doctors and tell them about what we've done here in Middle Tennessee?
Well, as we've discussed previously, I get a huge array of questions. And again, it depends entirely on who you're asking or who you're presenting the information to. A common thing is ringing in the ears, tinnitus. We get questions of how the device actually helps those symptoms go away. So they kind of want to see the connection between that and how that works. We get questions about the price of it, about insurance. Those are very common questions. If something works, that's wonderful, but how can my patient obtain that? That's what they want to know. So those are very common questions as well.
I'm glad you brought that up, Naomi. I'm gonna stop you right there. I don't want to get beyond that. Let's tackle that. Okay, let's confront the question about how much does it cost? Can my patients afford it, etc. Here in Nashville and Franklin, Brentwood, Franklin, where my practice is, we're in Middle Tennessee. We have doctors already. We have roughly 30 network providers throughout the Southeast, Midwest, and a few on the East Coast. I tell them they can, when they use the device, they can, charge whatever they want. But I'm going to tell you my story about why the device is a cash-only service. And let's confront that straight up, head on. When I started doing this for many patients, this is long before I had the patent and long before we had FDA approval. I used a code, medical code, for this. There's a dental code for a night guard. This is not a night guard, by the way. Let's cover that first. This is not a dental device. It doesn't do anything inside the mouth, nothing, zero. The only effect this device has is to decrease inflammation within the temporomandibular joint. That's all it does. No more, no less. If and when I did surgery on these joints, it was always, if it had coverage, it was always going to be covered under medical, never dental, never dental. Being that this device only has an effect on the temporomandibular joint, why in the world would you claim it to be a dental device or classify it as a dental device? Well, it's not a dental device. It's classified by the FDA and it's classified as the patent as a medical device. So it's a medical device. As a double degree oral and maxillofacial surgeon, I was used to using both sets of codes, but I would never use a dental code because it's not a dental device. So there is a medical code, continues to be a medical code that maxillofacial surgeons use. When I took apart the facial skeleton and put it back together in orthognathic surgery, we have a surgical splint and a code for a surgical splint, which is the device that you use to build out, so you don't make the face crooked, you build out from a constant point using a splint in the mouth that is used to put your face back, the skeleton back together. There's a code for that. And because the consensus and the usual and customary method, when there is no specific code, you use the code closest to, that's still accepted way to do it, code closest to what you're doing. So we had a device that, and this device actually is similar. I mean, for public, something that goes in the mouth, they all kind of look the same. So anyway, I use that code, that surgical code, and Blue Cross Blue Shield here in Tennessee actually covers probably 80% of the medical services in Tennessee. They're the big dog. So all of a sudden, I started using that code for this non-surgical device. And within a few months, I started getting these letters from Blue Cross Blue Shield. What are you doing? What's going on? Because we're getting all these, surgical splint codes. And I explained to them, well, I'm not doing surgery, but I'm using a device and we're using for a medical device and we're using this code. Well, we went on around and around for 2 years with Blue Cross Blue Shield about this issue. And they said, well, you can't use that code. And I said, well, give me a code. I mean, give me a code to use because it's a medical device. And they said, well, there is no code. So make a long story short, we traded letters and we traded calls and we traded letters and we traded calls for 2 years. And finally, because of my contract with Blue Cross Blue Shield, I had the right to call a meeting. And we finally had the meeting scheduled, and they came up to Nashville from Chattanooga, Tennessee, and the chief medical officer of Blue Cross Blue Shield and one of their chief attorneys and a couple of their executives and my attorney sat in my conference room, and I explained to them what I discovered, why I discovered it, how it came to be, why it worked, how successful it was, how much money it would save Blue Cross Blue Shield in doing all kind of weird and unsuccessful treatments for the temporomandibular joint symptoms. Remember that whole list of symptoms, not just earache or jaw pain, and the confusion between migraine headaches and temporomandibular joint pain. They're similar, they feel, how much money they would save. And after 45 minutes of explanation, the attorney sitting at the end of my conference table looked up at me and she said, Dr. Urbanek, there is no code. There is not ever going to be a code. We're not giving you a code. We're not going to apply for a code. And all the money that we sent you for that service, we want it back. That's called clawing back. They claw. That's a nice word for it. So anyway, I wasn't so devastated about the claw. I was devastated how ignorant they were. My attorney said, I was devastated. And my attorney said they didn't come to talk to you about negotiation or anything. They just, because you had the right to call a meeting, they gave you a meeting and they knew what the outcome was going to be. So it is a medical device. And actually they did me and all of us a big favor, because if you are a general dentist or an oral surgeon or an orthodontist who wants to do this service, there's no better way to build your practice than to have a cash only service that really works, that really helps people and solves the problem. So that is how it came to be a cash only service. In my practice, I charge $1,600 for the service. And it's a service. I don't sell widgets. We don't sell devices or splints. And I usually invest 45 minutes to an hour of my time, start to finish, consultation, delivery, and the follow-up appointments to the point where the patient will come in on their own on questioning what percentage of your symptoms, whatever their original symptoms were, what percentage of your symptoms are now diminished or gone. And when they reach an honest answer of 85% or above, then I don't ever discharge a TMJ patients. I say, come on back, see me if you ever have any more trouble. And that whole process takes me or my colleague, Dr. Urbina, who's now in the company, who sees most of our practice TMJ is done by Dr. Urbina. It takes 45 minutes of my time. So that question for you is now answered, and for the ENT doctors or the physicians or the PCPs, they now know, number one, it's a cash only service, but we have methods here in the office. That's how we market this and how we address it to patients is another 2 or 3 different episodes of this. We have learned that's how we have 600 referral sources now. We've learned how to address this to the doctors out there and to get their participation and their help in solving this problem. I guess pretty much that covers it. And Naomi brought that up, and I thought, well, let's just tackle this right now and not leave it to the end or talk about it when we talk about how to market this and get the word out to all the other doctors. Because as a dentist, as an oral surgeon, as an orthodontist, or whoever you may be who are thinking about or would like to participate in solving this problem with us, you have to kind of know that there is a marketing solution, how to get those doctors out there sending you the patients that they misdiagnose, don't diagnose, or misdirect. So, and that's what part of what Naomi is doing, is educating, making aware these doctors that, number one, there's a solution, and number one, don't misdiagnose it, not diagnose it, misdirect it. It's that simple. It's the whole thing. It's not complicated. So yeah, Naomi, I think that gives a lot of food for thought. What do the doctors say when what's their response when you say, hey, this is a cash service? I don't know whether you tell them how much we charge for it. I never ask you, but what's their response when you say, well, it's a cash service, and but we have care credit. We have an internal way that patients can pay for it over time. That we can talk about that sometime later on, but what do they respond, Naomi? How do they act?
Well, first, when you say there's no insurance coverage for it, first of all, you kind of get a little, not pushback, but you can see that they're thinking, okay, well, how in the world could my patients, be able to afford this, when I'm sending them over. And so that's when I go into the different payment options that we have, the 5 different payment options that we have, including care credit. And then, when you say 5 payment options, then, they're like, okay, you get it. There's so many different levels of skepticism, and then the financing and different stuff, that my job is to, like you said, just to educate, to cover every little detail about it. And when you go over the simplicity of the device, when you go over, well, and if you become a network provider, you don't have to deal with insurance. This not only builds your practice, but it also helps a large majority of your patients that you don't have to send out. You don't have to send across town to go to another office. When you bring home all the details of that, and that as a network provider, they have the ability to determine the price that they want to charge for their patients, according to what the majority of their patients can afford or can obtain, then you kind of see the light bulb go off.
Yeah. So just to clarify, now you're talking, because you actually have 2 roles in our business. Your role number 1 is to go out and to educate doctors in the Middle Tennessee community, and your other role is to educate doctors who want to join the network provider. And so now you're talking about network providers and doctors that you're talking to about that aspect of it. Yes. Right? Is that right?
Yeah, 2 different roles.
Yeah. Well, like I said, there's a lot to be said about how you enlighten, how you educate our colleagues, both our dental colleagues who want to do this and our other colleagues who don't want to do it and just send the patients to you. But I wanted to make this one, it brought to mind this one comment. Her comment made me think about one thing. This turns out to be a huge practice builder. Besides the fact that you have all these TMJ patients coming in your door that you can actually solve and help and fix, it's a huge practice builder from the standpoint of patients look at me as an oral maxillofacial surgeon. Of course, the average patient they do not understand the difference between a general dentist and an oral maxillofacial surgeon. They don't know the training. A dentist is a dentist is a dentist is a dentist to them. And they look at me when I've in that 85% of their symptoms gone, and with a big smile on their face, and they say, "Can you be my dentist?" And then I get a big smile on my face and I go, "No, ma'am, you do not want me to be your dentist. I haven't picked up a dental drill in, close to 50 years. And so the point is, but I do take out wisdom teeth and I do dental implants. And about 30% of those patients need a dental implant or 2. And they either, or they know somebody who needs their wisdom teeth taken out. And now that you have solved the 20-year problem for them, they kind of think you walk on water. And I can tell you that a great number of those patients either send their family, their kids, or themselves back to the practice to get the implants or their wisdom teeth taken out. Or then I have opportunity to refer them to, if they want general dental work, to one of my colleagues if they need a dentist. But it's a huge practice builder, because once you fix them, they want you to, they trust you. They want you to be their doctor. So we'll just end it on that, that comment as to how all this came about, why we're here, what we're doing, and why you might want to consider being a network provider. Or if you just want to ask more questions, you can contact Naomi at tmjservices.net, or you can contact me at Tony at tmjservices.net if you'd like to learn more about what we do and how we do it, how you can participate. The website is www.tmjservices.net. Give us a call, give us a text, ask us some questions. I really would love questions from anyone out there who has any question at all. We're very open, very transparent, and I think we can answer. I know we can answer any question out there, and there are no stupid questions. Hey, that brings in the fourth grade, I stood up and asked a question of my teacher. I'm not going to go into what the question was. I won't tell you the kind of teacher. It was the fourth grade. I remember that. Of course, you had to stand next to your desk. First, you had to raise your hand. Then you had to stand, when you were acknowledged, stand up next to the desk. And I asked a question, and my teacher glared at me and pointed her finger at me and said, "You can't ask that question. Sit down." I was terribly embarrassed. I mean, I had a classroom full of 50 kids. In front of them, sit down. You can't ask that. I was terribly embarrassed. And I sat down there, hung my head, and I thought for a minute. It took me a moment, not long. And I said, that might have been a stupid question. I might be stupid. That might have been a stupid question. But there is no way that, I couldn't ask the question. There's no way I couldn't ask the question, no matter how stupid it was. That had a profound effect on me as I got into high school, and I got into college, and I got into dental school, and I got into medical school. And I go by that mantra: there is no stupid question. And it came out of an experience I had in the fourth grade. Thanks very much for your attention. I appreciate all of you who are listening. And I look forward to hearing from any of you. And I look forward to speaking with you again. Thanks so much.
Thank you.